Well, hello and welcome everyone to our breakout session for this afternoon. It is my honor and pleasure to welcome Dr. Stephen Rosen, who's joining us today with the topic of the scientific approach to understanding cutaneous lymphomas. And for those of you who are not familiar with Dr. Rosen, I'll just chat a little bit about his background and an introduction. So he is the Provost, Chief Scientific Officer, and Director of the Comprehensive Cancer Center and the Beckman Research Institute, Irela Manella Cancer Center Director's Distinguished Chair for the City of Hope in Duarte, California. Boy, I got that all out in one line there, Dr. Rosen. Dr. Rosen's laboratory research focuses on experimental therapies and hematologic malignancies. And he's received numerous grants and awards and contracts, and he's published more than 400 scientific papers. He's the editor-in-chief of Cancer Treatment and Research and is the chair of the Medical Science Committee at the Leukemia and Lymphoma Society and serves on its board. He also serves on the board of the American Society of Clinical Oncology's Conquer Cancer Foundation. And closer to home, Dr. Rosen serves on our Medical Advisory Council and is a member of our Scientific Review Committee for our Catalyst grants, which we just announced previously. So we're really delighted, Dr. Rosen, to have you with us today. And without further ado, I'm going to turn it over to you, and we'll go from there.
Thank you, Susan, and welcome, everyone. I've been asked to give a little bit about the background of the biology of the cutaneous lymphomas. And so I'm going to have some brief slides to go through, and then we can have a dialogue. We'll start with mycosis fungoides, which is the prototype of the cutaneous T-cell lymphomas. And it received its name in the early 1800s by Dr. Alibert, because he felt that the skin lesions looked like a fungus, and that's why the word mycosis fungoides was penned. The majority of non-Hodgkin's lymphomas in the United States are B-cell lymphomas, B as in boy. But when you look at skin lymphomas, it's the exact opposite. The vast majority of the skin lymphomas are T-cell lymphomas. And so the T-cell lymphomas in the skin are very distinct, and they tend to be, in the majority of instances, very slow in progression, very indolent. We know a great deal about the biologic characteristics, which I've listed on this slide, and I see the slide's a little bit hazy, so I wouldn't worry about it. I'll just be talking through this, that we know many of the signaling pathways within the tumor cells. We also know the markers on the surface of the tumor cells. And in spite of the fact that we know a great deal about the biologic aspects of the disease, it's almost impossible to grow this cancer outside the body. And I'm going to come back to that, because it's the environment that the cancer grows in that sustains its ability to proliferate, to replicate. So I'm going to go to the next slide, which will be a little bit more apparent. There's many manifestations of mycosis fungoides, and it often presents as patches or plaques. It can progress to tumor lesions. Some are more aggressive and are tumor lesions to start with. What is fascinating is that the lesion on, say, the arm and the lesion on the leg in an individual patient, we know came from the same clone. And so even though the cells, the malignant cells, circulate in the bloodstream, sometimes almost impossible to detect them, they home into the skin. And it's very rare to have involvement of internal organs. That was one of the more fascinating aspects of the disease. And actually very early on, it led us to understand the homing of cancer in general, that cancer doesn't randomly end up in an organ. It's because the cancer cell recognizes something in that organ that makes it adhere to those cells. And so as a result, in the case of mycosis fungoides, you have a cancer cell. It's not clear what the origin is. There's been a lot of speculation that it's due to chronic immune stimulation, possibly due to just bacteria someone harbors in the skin. with a propensity for the development of the cancer, where the cancer may be initially as benign cells reacting to the pathogen, and then with time mutations occur. And so the leukemic form of the disease is the Sézary syndrome, and that was named by a dermatologist, Dr. Sézary, in the late 1930s. And this particular form biologically is very similar to mycosis fungoides, except there's an abundance of these malignant cells in the circulation. As you can see, the photograph of this hyperconvoluted nucleus within the malignant lymphocyte. And again, we know a great deal about the markers on the surface and the actual signaling pathways that exist related to Sézary syndrome. And then of the next slide, I'll show you that this is an extreme example of Sézary syndrome, but this is what we would contend with many years ago before we had some of the modern therapies that are effective in controlling the disease, where there would be total body erythroderma. You would have what's referred to as Leonine facies that the individuals would experience. There could be effects in the eyes that you would have constant tearing, and then what's called keratoderma affecting the hands and feet that could be disabling. But the manifestation that was most troubling in Sézary syndrome was the intense itching. And the intense itching was quite disabling. And fortunately, we have much more effective treatments at this juncture. But again, in this instance, even though this is a true leukemia, the disease is predominantly in the skin and the bloodstream. And rarely do you see organ dysfunction in patients with Sézary syndrome. And so that has led us at the City of Hope to focus on dissecting the environment in which the cancer cell lives. And what we do on all of the patients that present to the institution, and this is directed by Dr. Christian Querfeld, who is a dermatologist, dermatopathologist, and my colleague in this research activity. Every patient has skin biopsies, not just for the diagnosis, but for us to dissect the environment that the cancer is growing in, using a variety of sophisticated techniques to better understand why the environment harbors and sustains the growth of the cancer, and how we can enhance the ability of the immune system to kill the cancer by taking this environment and transforming it from an environment where the immune response is suppressed to an environment where the immune response is activated and can kill the cancer. The original work in this contextually was not done in cutaneous lymphomas, but mainly in melanoma, where investigators like Jim Allison, who won the Nobel Prize, showed that cancers would induce the production of molecules that was suppressive of an immune response against the cancer. And that if you blocked these particular suppressive molecules, you could activate an immune response to kill the cancer. And that's illustrated in the next slide. And here you see that we're targeting a specific ligand that's immunosuppressive called PD-L1. So they're antibodies against PD-L1. And if we block that PD-L1 molecule, it activates T cells that are suppressed to kill the cancer. And prior to the blockage, it's referred as T cell exhaustion, that the T cells just aren't activated because they're suppressed, and so they can't kill the cancer cell. And so we've started a trial with funding from the National Cancer Institute and the Leukemia Lymphoma Society, a trial that combines an antibody against this PD-L1 ligand, and the antibody is called durvalumab. And we combine it with a drug that we studied many years ago called lenalidomide. This is a drug that's actually in the thalidomide family, but it's immune stimulatory. And we've seen dramatic responses in many patients. Neither drug is currently approved for the treatment of cutaneous T-cell lymphomas, and this is the one trial combining both. And On the next slide, you'll see examples of before and after responses in patients who had failed many different treatments. And some of the responses have been quite durable now out at about 2 years. But yet it's not all the patients that are benefiting. And so we continue to study and better understand how this may work. And so here in the left panel, you see in individuals whose skin lesions are at the baseline. And then in the right, you see the after effects after cycle 8 in this instance of the treatment. And then in the middle panel, you see the back of an individual before and after cycle 13, and also the knee area. And so you can see how effective this treatment was in these 2 separate individuals. And we're trying to improve on this particular therapeutic approach. And then there's another very fascinating inhibitory molecule that's called CD47. And CD47 is a molecule expressed by the cancer, and it suppresses the activity of cells called macrophages, which can eat tumors. They can also eat viruses. And so here, what we're doing is, and these are local injections in this instance, we're blocking this CD47, and they're referred to as checkpoints. We're blocking it, and you can see the baseline in these 2 different patients before and then after treatment within a few weeks. Very rapid reduction of the tumor cells as a result of blocking CD47, which then allows for activation of an immune response against the cancer. And what you're seeing in that upper panel is that just about all patients with these local injections were having dramatic responses. And so the take-home message, what I want to leave with you is that the immune system is very important in regulating both the growth and the potential destruction of the cancer cells. That the cancer itself, we can't grow outside the body. It's not capable without having these immune cells in the environment that seem to nurture the growth of the malignancy. And so I feel that what you're going to see in the coming years not only is advances in terms of direct therapies against the cancer, as was noted by one of the awardees today, but also strategies that involve activating the immune system to attack the cancer. And that's where we're putting a lot of our energies at the City of Hope, and also trying our best to dissect both the biology of the malignancy, but also the environment in which the cancer grows. And so maybe with that, we can go to questions that you may have related to the scientific aspects of the cutaneous T-cell lymphomas, in particular mycosis fungoides and Sézary syndrome. Susan?
Great. Thank you, Dr. Rosen. That's so fascinating. And I'll just invite everybody to enter your questions in, and we'll take them from there as we get them coming in. Okay, so here's a question. What do different CDs mean? I have MFCD8+. Mm-hmm. Good question.
Yes, that's a very good question. So the CD is the nomenclature used to describe proteins or other molecular targets on the surface of cells, not just cancer cells, but cells in general. And probably one that would be most familiar for mycosis fungoides and Sézary syndrome is CD4. So CD4 was the initial molecule associated with specific forms of T cells, the helper T cells. And these are complementarity determinant regions. And so the CD4 cell is very critical for balancing an immune response. It happens to go awry in mycosis fungoides and Sézary syndrome, and the cells proliferate. But it's also the cell that's attacked by HIV. And so individuals who have AIDS, they actually have a dramatic depletion of CD4 cells. And a result of that depletion of CD4 cells, they're immunocompromised and develop a variety of infections. Interestingly, if you have a B as in boy cell lymphoma, very often your immune system is so perturbed that you don't respond to vaccines. And this has become very pronounced during COVID, where individuals with B-cell lymphomas will not mount the vaccine response, and they become very susceptible to COVID infections. Though interestingly, with the cutaneous T-cell lymphomas in general, the immune response remains intact and robust and can mount an immune response to vaccines. And in fact, many years ago, we did a trial with an antibody targeting a specific molecule that was on both B and T cells. And the patients who had B-cell lymphomas, they did not generate an antibody against the antibody that we injected, which was a mouse antibody. There was no activity. But in the patients with the cutaneous T-cell lymphomas, they all generated a very robust human anti-mouse antibody response, which precluded us being able to retreat. This was with a radio-labeled antibody for radioimmunotherapy. And so that's another interesting aspect of the biology of these diseases. Many years ago, when I was a fellow, I took care of the index patient who had a form of cutaneous T-cell lymphoma that tends to be more systemic and is endemic to different portions of the world, Africa, Japan, there's an island in Japan, South America, and it's caused by a virus. It's the first and one of the cancers we know caused by a virus called human T-cell lymphoma virus 1, HTLV1. And that also affects CD4 positive cells. And the initial index patient was in 1979 when I was a fellow at the National Cancer Institute. And about the same time, there were young men in San Francisco developing bizarre infections that also involved CD4 positive cells. And it was presumed it was a virus. Ultimately, it was called HIV, but initially it was called HTLV3 because it was assumed that it would be very similar to the HTLV1 virus because of the attack on the CD4 positive cells. And in one case, replication, the other case, destruction of the cells.
Interesting. Wow, very good. So you talked a little bit about T-cell exhaustion. And so here's someone was listening very closely. Can immunotherapies be effective now where did my question go? Where did it go? Can immunotherapies be effective if the patient has T-cell exhaustion?
Yeah, so the key issue is, can we reverse it? And we can't reverse it in everyone, but as I showed you in those photographs, we can reverse it in many. And in fact, what was very exciting in the project where we did the direct injections, just about everybody had a dramatic response. And so the question is, when we do it systemically, we didn't find it as dramatic. And the question is why? It was probably because the therapeutic we were delivering was being absorbed elsewhere in the body and it wasn't making it to the area that we need to get it to, which is the microenvironment surrounding the cancer. But a lot of the work we're doing, for instance, combining the PD-L1 inhibitor with lenalidomide, is to activate those T cells both by blocking the suppressive components, but also directly activating the T cells and macrophages through, in this case, lenalidomide.
Fascinating. So a multi-pronged approach to regenerating the underlying function of those T cells. Very, very interesting. Very interesting. Okay. Always a popular question. Are there diets that have been explored to improve the immune system to kill the cancer?
There have been many attempts to alter the immune response through nutritional approaches. None, to my knowledge, have been successful. There are anecdotes where someone said, I switched my diet and I feel that had a beneficial impact, but then never reproduced in a larger population.
Always a big question, but I guess the general consensus
The other concern is it's a two-edged sword. As I showed you, you can't grow the cancer outside the body. The immune system seems to be sustaining the growth of the cancer, enhancing its growth. And so sometimes actually activating an immune response could enhance the growth of the cancer. And in fact, along those lines, there's individuals who may say have an accident, cut themselves. And where a lesion didn't exist before, you'll see an accumulation of the malignant cells related to the inflammation that also occurs in that area.
Fascinating. So still a lot more we need to know, right? From so many things.
And I wouldn't want to discourage anybody from not eating a very healthy diet. At the same time, diet is very important for general health. And fortunately, this is a disease that's slow in progression. So patients can live many decades, even though sometimes we have to deal with the cosmetic components. Right.
Eat healthy, get sleep, lower your stress,
yeah.
Exercise, right?
Yeah.
Let's see, here's a specific question. Does City of Hope do DNA testing analysis? And if not, how important is it in treatment to have that kind of testing done for treatment purposes?
I'm going to have you repeat it. You were going in and out.
Yeah. Okay. Let me see. Where did my question go? I guess they're asking, you do the DNA testing and analysis at City of Hope. And if a patient is being seen at an institution that isn't doing that same level of testing and analysis, how important is that in looking at treatment for the patient? So you do a lot of extensive kind of DNA.
So ours is more at a research level. We're trying to understand the disease. It does not impact on the therapeutics at this point outside of the trials we're doing. So I gave you 2 examples of trials that are not approved drugs, the anti-PD-L1 with lenalidomide and then the anti-CD47. So we're trying to better understand who responds and who doesn't respond and why. And so that's why we do the sophisticated testing. We also, there's a percentage of patients, it's a small percentage, fortunately, that develop a transformation to a more aggressive form of the disease called large cell transformation. And by doing these analyses, we've detected some specific targets that seem to be critical, and we're developing new therapeutics based on those targets. In this case, taking advantage of modern molecular medicine and making actually what we call antagomers to specific signaling molecules.
So maybe down the road in the future, as we figure out more about that microenvironment and we have diagnostics that can understand it, then we'll be able to apply the therapeutics to that information. But we're not quite there yet, but you're working on that.
Yes.
Very cool. All right, so let's see. Here's this question. Are you familiar with the link between serotonin reuptake inhibitors and mycosis fungoides?
I'm not aware of any therapeutic that is in that domain.
Okay. And that was a new one for me too. I hadn't heard any of those. Let's see. Will having Graves' disease change anything about my diagnosis of MF?
For Graves' disease is hyperthyroidism, essentially on an autoimmune basis. And not that I'm aware of that it would particularly affect the growth of the cutaneous T-cell lymphoma. It has its own manifestations, which may complicate the disease. Usually it's easy to treat the Graves' disease and control it. But during the interval, maybe prior to the diagnosis, there may be confusing symptoms that could be thought to be associated with the mycosis fungoides or Sézary syndrome.
I guess that brings up a good point in, capturing data from patients, right? So looking at those that have different diseases in addition to a cutaneous lymphoma, and what is that impact between the 2 different diseases and treatments. And we've got a lot, probably have some more things to learn in that instance.
Yeah, but a very important point, because obviously as humans, and those of us as we age realize there are a whole host of medical issues we contend with. Then mycosis fungoides and Sézary syndrome in general is a disease of older individuals, with the average age being about 60 or so when the diagnosis is made. So,
yeah, right. Lots more to learn. Let's see. Someone wants to make sure that they heard correctly. You said that B-cell lymphomas don't respond to the COVID vaccines or to vaccines. Is that also true for cutaneous B-cell lymphomas?
So it's cutaneous B-cell lymphomas, which make up the minority of skin lymphomas, also can have alterations in their immune response. It's usually not as profound as the systemic B-cell lymphomas or the chronic leukemias that are B-cell malignancies, like chronic lymphocytic leukemia, which has probably the lowest response to vaccines. So patients with cutaneous B-cell lymphomas, their immune system can be perturbed, but usually not as severely perturbed as the systemic B-cell lymphomas.
Mm-hmm. Good point. Because I'm sure from a patient perspective, especially given that our cutaneous B-cell lymphoma patients are in the minority of the minority, right, within the cutaneous lymphomas, and you hear all this information out there about, B-cell lymphoma people, don't respond well to the vaccines. It can be very confusing. So thank you.
So one thing we're doing for all of our patients, and this is not just City of Hope, it's becoming more universal, for our B-cell lymphoma patients who are not responding to vaccines, we're giving a passive antibody called Evusheld that circulates for about 6 months. And if you're infected with COVID, it'll bind to the COVID and prevent the severity of the infection. And I've had patients who've gone to gatherings where everyone got COVID. Now it's spreading at the present time. Fortunately, it's a very mild variant of Omicron that seems to be spreading rapidly, where everyone felt ill. My patient, who ironically was the most immunocompromised, who also was infected because became antigen positive, didn't have any symptoms because of the Evusheld. So we've been doing that routinely.
Good to note. Good to note. Always a very good question. Hearing that there is no known causes for cutaneous T-cell lymphoma, sounds like your work may shed some light on this.
So I didn't hear the very beginning. You broke up just
the causes for
the causes.
The causes.
So many years ago, I published. It was actually in the 1980s that there was what we call an HLA association with Sézary syndrome, and that suggested that it was in the autoimmune family. In fact, the antigens we saw, which are these molecules expressed on immunologic cells, were similar to what you would see in patients with rheumatologic diseases or type 1 diabetes, which are autoimmune processes. We couldn't demonstrate it in mycosis fungoides, and the association may not be as intense, but clearly there's a response that's happening in the skin that allows the cells to replicate, and then they go through mutations that lead to the malignancy. And there has been a presumption that what initiates it is some sort of pathogen, potentially in the skin, that's stimulating the immune response in the skin, and the cells then home to the skin, they replicate, and then mutations occur. So one of the projects we have here is to expand what's historically been known about skin infections and to look at their association with the disease, and because we have one of the major centers in the nation for the microbiome to look at pathogens. And it's housed in Phoenix at a research institute that City of Hope acquired called TGen. And so they're not only engaged in looking at a variety of pathogens that the Department of Defense would want to know about, or COVID, but now they're also engaged in looking at the pathogens harbored on the skin of our patients with cutaneous lymphomas.
Interesting. Well,
and obviously comparing it to healthy controls.
Sure. Well, that's something we'll definitely have to keep an eye on. We'll have to ping you as you learn more about that. Curious. Okay, 2 questions for you. Can you explain again how our inside organs are not the primary site to become cancerous, although we have a blood cancer?
So that's a very good question. Not one that I have a definite answer, but this disease initiates or appears to initiate in the skin. And the cells we know circulate because, as I said, that if you biopsy an arm lesion and a leg lesion, they're from the same clone. So it's circulating but harboring in the skin. With time, you do get an accumulation as additional mutations occur in the cancer, and they'll go to the lymph nodes and potentially to internal organs. Interesting that the bone marrow to some degree is spared. It would only be a very late manifestation, even though you would think as a blood cancer, the bone marrow would become a very common spot. The same is true of the spleen. In many of the B-cell lymphomas, the spleen is predominantly involved from the beginning. And again, it's not a common manifestation within the cutaneous T-cell lymphomas.
Okay, and then the second question, the second part of the question is that they have had a lot of blood testing done in the past, but was diagnosed with MF after the skin biopsy. Why couldn't my diagnosis be done by the blood testing? Good question.
It's a very good question. Right now, we don't have markers in the blood outside of the malignant cell that would diagnose mycosis fungoides. And even though we know the malignant cell circulates, it's at such a low concentration, it's very hard to detect it.
Mm-hmm. So this is another question kind of along these lines, which I think is so interesting. And I think it's, from a patient perspective, when you learn you have this disease, it's hard to wrap your head around. It's in the skin, but it's a blood cancer. How does that equate? It's not a skin cancer, right? So this gal is asking, since this is a blood cancer, how do specific lotions or things that you apply to the skin really benefit the areas of the skin? So I guess where are those, why do topicals work if it's a blood disease?
Mm-hmm. So some of the topicals we use kill the cancer cell or affect the microenvironment, like nitrogen mustard as an example. It's a chemotherapeutic. There are some, like a Miquimod, that may stimulate an immune response against the cancer. And so, or some of the topicals, the retinoids that are applied topically, they can both kill the cancer, but also affect the immune system. The emollients that are used, it's mainly to provide comfort and not really to treat the disease. It may take away the itching. I think individuals will say that if they have an infection, for instance, that the skin can look worse. And so sometimes antibiotics, because they'll control the infection and therefore reduce the inflammation against the infection, you'll see an improvement in the appearance. It won't cure the disease, but it'll make it more quiescent. Mm. But this fascinating balance of the immune system, both nurturing the growth and potentially killing the cancer, there we want to tip that balance to get more killing and not nurturing the growth.
Right. So hence all the work being done to really understand that immune system interaction and response of what you're talking about in the microenvironment, and understanding where it's suppressed, where maybe it's overstimulated, and figuring out how to fix it. Right. Let's see. So we have someone who's from London and asking about recruiting on clinical trials. And I know we've got quite a few international clinical trials that are underway, and maybe you can talk a little bit about the collaboration internationally and kind of the work that everybody's doing collectively.
So most of the international trials would be driven by pharmaceutical companies. It's very hard to get grants that then support international investigations. Interestingly, because of the expense of doing clinical trials, it's challenging if something is not making money. I'll give you an example. We've repurposed a drug that's generic for the treatment of COVID. Initially repurposed it for the treatment of a blood cancer called myeloma. And the drug is called leflutamide. It was used in hundreds of thousands of individuals with autoimmune diseases. And it's very effective. And in myeloma, we showed it works. And now we have a grant from the National Cancer Institute to see if we can prevent high-risk smoldering myeloma, which is a precursor, from evolving into myeloma. And that's through a grant. We also got a grant to use it to treat COVID. And the reason was that I knew it was anti-inflammatory, which is what usually causes the damage in the lung from COVID, but also antiviral. And it's been shown to be a very effective drug against a variety of viruses because it inhibits a specific base that is part of DNA, a pyrimidine base. So the drug itself to treat a disease like COVID is $100. That's it. And all of these other drugs that are out there now, we're talking about thousands of dollars, is $100. But at City of Hope, we see very few patients who have COVID because we're not a general medical center, we're a cancer center. And now in particular, it's very uncommon that we'll have patients who are ill. And the FDA put a lot of restrictions on the trial. They had to have failed another viral medication called remdesivir. They had to have severe pneumonia. They had to be hypoxic with a low oxygen. And so we put a few patients on and everyone benefited. Patients who, even on a ventilator, a fellow who with 2 young children got off the ventilator, it failed everything. But then when I wanted to advance it, the company that had developed it, Sanofi, had no interest because they don't make money on it. And if I talk to colleagues at other institutions, not that they're not interested, but to be part of the trial would cost them thousands of dollars in data management, even though the drug we're giving to them, and it's very inexpensive, but it's a great cost to them to do the trial, whereas pharmaceutical companies are giving them $5,000, $10,000, if not more, to look at their new drugs. So part of it is the reality of commercialization when you do these investigations of a new therapeutic. Now in London, you have a very famous leader in the field, Sean Whitaker, and he is a pioneer, a dermatologist pioneer in the therapy of the cutaneous T-cell lymphomas. But you had mentioned earlier, Susan, that we're going to all gather in Madrid in September, and where all the latest data is presented, and we all collaborate and work very closely together. We're going to have the international meeting here in Los Angeles in 2 years, where all the world's experts will come. And you and I have been chit-chatting about how to most effectively engage the Cutaneous Lymphoma Foundation and all the patients who benefit.
Yeah, we're excited for all of that. I think one of the great things about this particular community, disease community of both patients and researchers and clinicians is it is so collaborative and everybody connects and works together, which is really wonderful. And so appreciative. Let's see, another question. Are there effective antioxidants for the skin? Anything that you could put on the skin that would help? I guess.
Not that I'm aware of that are effective therapeutically, but it's a very good question. And,
yeah, interesting question. Yeah. Okay, this is a very specific question. It sounds like someone's got MF and endometrial cancer. So I guess the question then is, for some people, unfortunately, you may have 2 different cancers, right? And in the case of MF, being probably the more indolent, slow growing, how do you manage? Do you do both? Do you do them one at a time? Like what kind of approach might you take?
Right. And so it's not uncommon because individuals with cutaneous T-cell lymphomas will live for decades with the disease, that other cancers will arise and they could be more aggressive and have to be addressed immediately. Sometimes the therapy applied to the other cancer may benefit the individual with cutaneous T-cell lymphoma because it's immune therapy or chemotherapy, even though we historically have shied away from using chemotherapy in the cutaneous T-cell lymphomas. It is active. There are certain drugs, for instance, methotrexate, that can be very effective in certain instances. It's an anti-folate type of drug. There's a drug called Doxil that is similar to adriamycin, a drug we use in a variety of cancers, but it's wrapped in a lipid. And so it, for whatever reason, doesn't cause hair loss. It doesn't seem to home to the skin, but it's very effective in treating in particular tumor forms of cutaneous T-cell lymphoma.
So both, and have all your specialists talk to each other, I guess is the recommendation, right?
There was a question earlier about the CDs. So there are certain CDs that could be expressed on the malignancy that then allow for new therapeutics, one being CD30. And CD30, there's an antibody linked to a toxin that's very effective. And if it's overexpressed, we can often get dramatic responses. Then there's an antibody that is in particular effective in Sézary syndrome. There's actually two of them. There's one that's a little bit too immunosuppressive that's against CD52 called alemtuzumab or Campath. And we've published on it, even had patients who went into sustained remissions with Campath. But now there's a equally effective but less toxic drug, mogamulizumab, that's specifically against a cell surface receptor CCR4, and CCR4 also has a CD number that's used. And this one is fascinating because it can be very effective. Patients can enter a remission, but then develop inflammation in the skin that looks like the disease, but is really an autoimmune phenomena and not the cancer itself. And trying to sort that out can be very challenging. And this is another project that Christian Querfeld is leading.
Yeah, good stuff. Okay, this is a good question and a general one, since a lot of early stage patients use the potent topical steroids, but do they really kill the cancer, or do they, and complement other therapies? I know a lot of people do multiple therapies at the same time. So I guess, does it really kill it, or how does that kind of work, especially?
What was the therapy that was being added?
It was a topical steroid, so clobetasol
So they do two things. In fact, this is an area of my own research over the years about the expression of the receptor. So within immunologic cells and within blood cancers, there's a receptor called the glucocorticoid receptor. And it's absolutely fascinating. The steroid enters the cell because it's lipid soluble. It binds to this receptor. The receptor then changes its conformation, enters the nucleus, and affects a whole host of genes, turning some on, turning some off, and leading to a cascade of cell death. So it actually will kill the cancer. You can become resistant because you lack the expression of the receptor, or the receptor gets mutated, or sometimes the genes that it affects don't get expressed. But the glucocorticoids will affect both the microenvironment and the cancer. So it's not just the cosmetics that improves, it actually kills the cancer.
And therefore can be combined perhaps with other therapies, and you're getting kind of two different mechanisms of actions, I guess, in killing in the different things. Good point. Let's see. Yes. Well, I think we answered that question, that you can use those kind of topical steroids in combination with other maybe systemic agents or other kinds of, and you kind of get a double action there. Okay. So let's see. Can you speak to the overall prognosis of primary cutaneous marginal zone B-cell lymphomas? We've had a lot of B-cell people today. What is the potential percentage risk for B-cell to develop into other cancers, and what is the most common type of extended cancer?
So the marginal B-cell lymphomas of the skin tend to be very indolent. We often do not treat unless it's a cosmetic issue, and then it's usually local injections of steroids. And on rare occasions, we'll use systemic treatment. The prognosis is so good that at the most recent discussions in Chicago, where a group of us got together to talk about all blood cancers, and it was pathologists and clinicians, The marginal zone lymphomas are now going to be classified as lymphoproliferative diseases and not lymphomas because they behave in such a benign fashion. And I have patients I've now taken care of for 30 years who've not required any intervention. So the prognosis is good. It's very rare that they transform into a more aggressive lymphoma. There are anecdotal reports, but very rare.
Good to know. Very good to know. So is it okay to relax in a swimming pool or a hot tub?
Yes. In fact, I'm planning on doing it this afternoon.
That sounds lovely. That sounds lovely.
Yeah, but it's not something, it won't exacerbate the disease. You know, it may make the disease initially look worse because you're getting blood flow to the skin. And so, you know, that can give the appearance of the disease being more apparent, but it's nothing to worry about.
Yeah. Or it could dry your skin out. I mean, if you're in a pool with a lot of chlorine and things like that.
It won't make it worse, and this is not a contagious disease. You don't spread it by touching anybody. Right.
Let's see. Does having MF affect having MF make you more likely to get or change your ability to fight other skin-related viruses or diseases, skin cancers or other type of skin diseases? I guess, does it really impact your capacity?
In general, no. Sometimes, unfortunately, the treatments that we apply, like light therapy, may put you at higher risk to develop skin cancers. There's an irony that light therapy is very effective to treat mycosis fungoides, but it can cause skin cancers, basal or squamous cell cancers or melanoma, but it's very effective. In fact, often because the sun-exposed areas of the body are being controlled, you see the disease manifesting itself more on the trunk than, say, on the hands, or rarely on the face, in part because of the light infecting it.
Right. So
years
probably
ago, I had an interesting experience. We had started trials with interferon, which can be a very effective treatment, which affects both the cancer cell and the microenvironment. And I had a patient who had started on the therapy and had a death in the family. He was in Chicago, it was February, went to Arizona for 2 weeks, and he was wearing a V-neck t-shirt. When he came back, all the areas that were sun exposed dramatically responded, much more so than the patient's areas that were hidden by his t-shirt. And so we started a trial combining light therapy with interferon, and it turned out to be the most successful treatment that we did.
Wow. I think there's something to that, right?
Today it's probably the most successful treatment available.
Yeah. Boosting the immune system, or activating the immune system, and then killing the disease in the skin, giving the immune system a shot. Yep. Let's see. Someone says they've heard differing views on being more susceptible to melanoma when having cutaneous lymphoma. What's your thought?
So I don't think the cutaneous lymphoma itself predisposes to the melanoma. But again, light therapy can increase the risk of melanoma.
Right. Especially for those of us who are fair-skinned and more susceptible in general. Yeah. Well, we have a few minutes left here. Here we go. What exactly does UVB therapy do to curtail the manifestation of MF in the skin?
So it both, again, kills the cancer, but also affects the microenvironment. And we honestly don't know enough about what's going on in the microenvironment related to the UVB therapy and why that is effective. In this instance, it's probably that there are cells that are sustaining the growth of the lymphoma, and by killing them with the light therapy, it's allowing for whatever those we call them cytokines, those proteins that sustain the growth, they diminish, and then the cancer regresses. It is effective.
So you're basically killing the food mechanism for the cancer to grow.
Yeah, it's a good way of thinking of it. It's a combination, but not adequately studied.
Right. Lots of work we still have to do, right? So in our last few minutes here, and we've had a lot of really good questions. I'd like to ask you, what do you see as kind of the exciting areas of research and therapeutics? I mean, you're doing a lot of work in the field and looking at
where I would invest my energy, what we're doing here is in two domains. One is the study of the microenvironment and more effective therapies to stimulate immune response. With colleagues from the Weizmann Institute, we've defined a new target. This did not start in cutaneous lymphomas, but it would be applied to cutaneous lymphomas as well. And we've shown that blocking this target in a variety of blood cancers and solid tumors in preclinical models stimulates an incredible immune response against the cancer. And so we're hoping to ultimately advance this as a therapeutic that would benefit patients with cutaneous lymphomas as well. We also have identified specific targets in the malignant cell, and we've done screens of libraries to come up with chemicals that'll essentially bind to the signaling proteins and enhance the death of the cancer. And so we have one compound that's being advanced with colleagues at Northwestern as a nanoparticle. Again, some of the practical aspects of advancing therapeutics, if the molecule exists and you more or less just figured out how it works, very often you can't get intellectual property around it, so you can't commercialize it. And so you have to modify it in some way in order to get commercialization for it then to be brought to a larger population. And then with Christian Querfeld, we also, in this form of cutaneous T-cell lymphoma, where it transforms the large cell transformation, which is much more aggressive, we've defined some of the RNA. So DNA goes to RNA, goes to protein. And in RNA, there are non-coding RNA species that are called microRNAs. This, again, was a Nobel Prize discovery that don't seem to themselves make proteins, but they tend to control all of the gene expression in a cell. And we've found some that are overexpressed in this large cell transformation, and we've made antagomers against them that bind them in the cell, and as a result, the cell dies. And so we're advancing those therapeutics here at City of Hope.
Wow, sounds exciting and a lot happening there. Yeah. All right, well, we have another question because that always happens, right? And I think this goes back to, and you were talking about this, as we age, we sometimes have additional health challenges that are probably not related necessarily to MF, but someone's asking about the correlation between prostate and lymphomas in general, if there's any correlation.
So there's prostate cancer is very common. It's said that if you just did autopsies on every male at the age of 90, about 90% would have some elements of prostate cancer, though many prostate cancers don't require therapy, even when diagnosed in younger men. So there's no direct correlation. It's just one's very common, and then you happen to have a rare disease, the cutaneous T-cell lymphoma. One of the other issues is when you're on certain medications, they can cause other medical conditions. So as an example, the rexinoids like targretin can cause lipid issues. And so you have to worry about making sure you're not causing hypolipidemia and cardiac problems. And so every medication carries, some concern.
Right. Right. Hence, why it's so important to look at all your options and take into consideration the whole person, right? Not just the disease. You've got to look at the whole thing. And especially in this particular group of diseases that are, at least today, right, not curative, and we're treating long-term. So trying to understand the long-term impact, even if you're doing something like light therapy, could have a long-term impact if you're using it for decades, especially in a fair
skin. Which will cause aging of the skin. There's no way of getting around that for all of
Yes,
us.
unfortunately, I am experiencing that myself, having had a lot of PUVA and UVB and
Yeah.
over the course of time. And now that I am decades beyond my active treatment for my MF, I'm now seeing the long-term side effects. Not so happy about that, but oh well. Well, Dr. Rosen, I know we're coming up upon our time. Is there anything else you'd like to share with everybody before we let you go and enjoy the rest of your Saturday and
Just to
dip in the
thank
pool?
you, Susan, and to reiterate the value of the Cutaneous Lymphoma Foundation and the impact you've made throughout the world and to the benefit of all our patients with this disease. And I would hope that everyone who's engaged today feels a commitment to the Cutaneous Lymphoma Foundation to help sustain your good work.
Okay, thank you. Thank you so much. And help us support more research and young researchers and bring more folks into the field because, you know, without
the young woman from Washington, Akkad, her mentor, Dr. Nina Shah, she was my student at Northwestern. And so she used to come to the Cutaneous Lymphoma Clinic with me. And her first publication was with us, I believe with Christian Querfeld on probably interferon, but it may not have been interferon in cutaneous lymphomas.
Yeah. It's wonderful. And I will say thank you to you and Dr. Querfeld and the physicians in the field who are really dedicated to supporting the young investigators and the young researchers and the students and engaging them and getting them excited about doing their long-term work in cutaneous lymphoma, because without that mentorship, you know, they would find somewhere else to go. And it's really wonderful to have that kind of the young thinking and the new minds coming into the field. So thank you for your support of our young investigators and our young folks as well. You've really had a huge impact. Your time at Northwestern and now also at City of Hope. We're very grateful to your dedication as well. So together we'll do great things.
Yeah.
So thank you, Dr. Rosen. Enjoy your pool time. And,
thank you.
Have a good afternoon. And thank you, everybody, for your questions and your thoughtful inquiries. And we're a few minutes out now for, I think we're going to a break. So you can gather any additional questions that you have for our last Q&A live panel with Dr. Pinter Brown and Dr. Chung. So you'll have another opportunity to ask questions, perhaps from a different angle. So things that may have come into your head. So we'll look forward to seeing everybody at the last session in the open Q&A. So thanks, y'all, and time for a little break. Grab a snack, cup of coffee. That's what I'm going to do. And we'll see you all soon.